They're going to be.
Good afternoon. Welcome, everybody. Thank you so much for joining. We will give just a minute or a little time for some more people to filter in, and then we'll go ahead and get started. All right, so it is the top of the hour, so we will go ahead and begin. So good afternoon, everybody, and welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Sovich, and I'm a public health program manager at the Hepatitis B Foundation and the manager of our Hepatitis Delta Connect program. Thank you very much for tuning in today. Today's webinar will be focused on the work and research of Dr. Wang and Bijou Hunt, who recently conducted a pilot program to perform hepatitis delta testing for individuals who tested positive for hepatitis B surface antigen in 8 different healthcare centers around the United States. They will share the prevalence of hepatitis delta found in the study, as well as barriers and successes in incorporating hepatitis delta testing into the hepatitis B care cascade and lessons learned throughout the project. These findings can have important implications for future work in the area of hepatitis delta, particularly as novel treatments continue to move through the clinical trial pipeline. So we look forward to a great presentation today. Next slide, please. Before we get started, thank you so much. Before we get started, I would like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box, and we will address it as soon as possible. At any time during the presentation, you can enter questions into the Q&A box, and questions will be addressed by Dr. Wang and Bijou at the conclusion of the presentation. And the session is also being recorded, and the recording will be shared following the webinar. Next slide, please. Just to provide a quick introduction about and background about Hepatitis Delta Connect. This is a dedicated program of the Hepatitis B Foundation, and it was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support to those living with and affected by hepatitis delta through a variety of different channels. These include email and phone consults, social media, newsletters, blog posts, a website, different fact sheets, focused advocacy efforts, and webinars such as this one. We also run hepatitis delta focused events and lead hepatitis delta public health research projects. We are hoping to continue to build and expand our programming throughout 2025 and in the years to come, and we will keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you very much. So today we are very excited and honored to be joined by 2 speakers, Dr. Wang and Bijou Hunt. Dr. Wang is the medical director of the Chinese medical program at Cooperman-Barnabas Medical Center in Florham Park, New Jersey. She is a board-certified internal medicine and pediatrics, and primarily specializes in adult primary care. She's committed to Asian health and wellness, as well as the clinical identification and treatment of hepatitis B, including infections in pregnancy. And she's also the senior advisor for global health at the Hepatitis B Foundation. Bijou Hunt is the director of the Sinai Infectious Disease Center in the greater Chicago area, and she is also an epidemiologist and the lead author of this study. So we're very excited today to hear from Dr. Wang and Bijou, and are grateful to them for joining us. Again, audience members are invited to put any questions you may have in the Q&A box as they arise, and they'll be addressed at the conclusion of the presentation. So without further ado, I will pass it to Bijou to begin the presentation. Thank you so much.
Thank you. Give me one moment to pull up my slides here. Okay. Can you give me a thumbs up, Beatrice, if you see that? Great. Okay, hi everyone. I'm Bijou Hunt. I use she, her pronouns, and I'm the director at the Sinai Infectious Disease Center in Chicago. I'm very happy to be co-presenting today with Dr. Wang because I want to give the disclaimer that I'm not a doctor. I'm not a hepatitis expert. I would confidently say I'm like an expert on the work that we did in this collaborative. But I'm happy that we'll have, clinical questions can be fielded by Dr. Wang. So I'm going to present the findings from this really wonderful pilot project that we were part of. I'm going to walk you through kind of what we did, what we found. Anybody that's read the paper, this will be kind of a review that was published in Journal of Viral Hepatitis, I think in late 2024, I want to say. And certainly if you've read it and this is review, then the Q&A will be at least not review for you. So just kind of setting the stage of where we were when this study got started, this pilot project got started good couple of years ago now, which is hard to believe. But so the landscape then, and I think it's still fair to say the landscape now, we were approaching this from this, with sort of these facts that HDV prevalence and risk factors remain understudied in the US, that the HDV screening guidelines are contradictory and unclear, and that a better understanding of HCV prevalence, risk factors, and guidance for screening is needed. So this multi-site pilot was undertaken by Focus, both governmental affairs and medical affairs, and it was launched in April of 2022. So we're coming up on, it was about 3 years ago now. And really wanting to examine HDV prevalence, as well as laboratory practices, which I think is one of the really sort of interesting things that we did here. And then to also think about potential approaches for screening and linkage to care. So there were 9 agencies invited, 8 agreed, and those that were invited based on criteria that they were conducting routine HBV screening and linkage to care, that there was a seropositivity of Hep B surface antigen greater than or equal to 1%, a minimum of 4,000 HBV tests per year, a proven dissemination track record, and then experience serving impacted patient populations. So let's take a look at the sites, and we'll have a couple slides on the sites, so I'll highlight certain things in certain places. But overall, these were the 8 sites that participated. We had a combination of kind of EDs, inpatient, community health centers, as well as sort of like the larger hospital systems. And this was a geographically diverse set of sites. I actually want to just kind of bring us to this next slide, which is fairly busy, but if you'll stick with me, I will kind of draw your attention to a couple things here. The first thing being that all of these sites were urban or suburban. So we did not have any rural sites participating in this pilot, but all of the sites were really serving primarily Black, Hispanic, Asian populations. All the sites had a lot of services for immigrant populations, and the one exception I would just call out was Norton, our partner out of Louisville. They were seeing a lot of injection drug use. So just pointing that out. And then the other thing I want to call out here is just the variation in lab partners. And again, that will be sort of an interesting part of the discussion when we start thinking about the different processes that were undertaken across these sites to try to achieve this goal of performing Hep D testing for all Hep B surface antigen positive patients. So we've got LabCorp, Alverno, Quest, and then actually I realized I've never said out loud RUP. I don't even know how to say that lab. So that's, I've only ever written it 100,000 times, but so there were, a variety of labs, and we throughout the pilot, like we all had sort of different barriers to what we were able to do based on our lab and other characteristics as well. So here in this, I guess, diagram, I'll call it, this is helping us understand the different ways in which the sites in this pilot project approached the sort of, I guess, what I would call testing cascade. And so I'll first call attention to Newark and Norton, where you see 3 squares all in a row. And what that means is that the same sample was carried through for Hep B testing, Hep D antibody testing, and HDV RNA testing. Whereas if you look at the first 2 rows for Cooperman and NYU Langone, for example, you'll notice that the first sample was used for testing for HBV and HDV antibody, but then another sample was needed subsequently collected to perform Hep D RNA testing. So there's some variation across sites, and again, this kind of gets to some of the barriers that we'll talk about later. We also kind of divided into what we called manual reflex testing versus add-on testing. So for example, Sinai, we're the last row here. We fall under the add-on testing and the same sample used throughout. So at our site, for example, we would run a daily report to look for any Hep B surface antigen positive patients. And then if we found any patients, we would complete paperwork and fax it to complete what we called the add-on testing. So we had to add on orders for the Hep D antibody and the RNA. And we decided to just do both of those because we figured if we don't do the RNA at the same time and the HDV antibody comes back positive, it will be very challenging for us to bring that patient in to get another sample to do the RNA test. So we were a little bit unique in that. Whereas our friends who were doing what we called manual reflex testing, they had more lab processes that tried to carry through the testing a little bit more automatically. But even there, the language gets a little tricky, where it's not reflex testing the same way that we think about Hep C reflex testing. So we didn't have anything quite that automated happening. So without falling too far down that rabbit hole, because I want to save that for kind of Q&A and discussion, I'll just move on just to say that we all had very different approaches. Again, it was, sometimes related to what our labs were capable of doing, but it presented its own series of challenges across our sites. So now I just want to walk us through the data. Again, these slides are going to be taken straight from the paper. I think the slides are going to be shared, but if you want to check out the paper, I think that was published as open access, so it should be widely available. So just to kind of orient us here, in our very first column, we have data on just all Hep B surface antigen tests across the sites in the collaborative. Then we have information on the number and percent positive for Hep B surface antigen. Then we move into the number that were tested for HDV, so both for antibody and RNA. So I'm going to walk us through these findings kind of step by step here. So the first thing to just call out is that collectively the collaborative performed Hep B surface antigen testing in a total of 100,693 unique patients. So that's kind of like our first marker here. What we observed was just over 1,000 Hep B surface antigen positive patients. So positivity for that was about 1.04%. Now, just to call a few things out, still staying in this first column of Hep B data, what we see is that while the majority of our Hep B surface antigen testing was performed among females, there was a slightly higher proportion of Hep B positive results occurring among males compared to females. And then sort of similarly, while the majority of our testing was performed among persons of Hispanic, Latino ethnicity and those identifying as non-Hispanic Black, the largest portion of Hep B surface antigen positive results was actually observed among persons identifying as non-Hispanic Asian. Oh, did I skip one there? No. Okay. So moving to sort of our next column, which is the Hep D testing, we see that 645 individuals were tested for Hep D, and this is a completion rate of only 58%. So that's kind of our first flag, if you will, for the pilot, that the completion of sort of this testing cascade, if you will, really started to fall off here, where we should have seen, oh, we would have liked to see a lot more people completing Hep D testing than we did. And that just relates back to some of the barriers that I referred to and that we'll talk more about, hopefully in discussion. So 58% completing Hep D testing, and with 9 antibody positives, we saw an antibody positivity of 0.81%. Here we saw that the antibody positive results were observed across all racial and ethnic groups. So we had 1 each among non-Hispanic white and Hispanic Latino, 2 among non-Hispanic Black, and then 5 among non-Hispanic Asian. Now jumping over here to our RNA positive, our positivity was 0.18, and we saw 2 RNA positive patients, 1 non-Hispanic white, 1 non-Hispanic Black. So again, we had a total of 9 antibody positive results, and then 2 of those were RNA positive. So again, prevalence 0.18 for RNA positivity. So just taking a closer look at the patients here. So first we'll start with the antibody positive that had the RNA positive, which again was 2 out of the 9. So the first RNA positive patient was a non-Hispanic white male, age 49, from Ukraine, no co-infection with Hep C or HIV. This patient was tested for HPV during refugee screening, and the patient viral load at time of diagnosis was 68,500. The second patient was a non-Hispanic Black male, age 31, country of origin Eritrea, no co-infection with Hep C or HIV, and no history of substance use, and viral load at diagnosis was over 5 million. So then we had 5 patients that were antibody positive with confirmed RNA negative result. The first patient here was a 52-year-old female from Philippines with a history of deceased donor renal transplant and a history of chronic Hep B. The second patient was 56, from a female from Afghanistan, no co-infection, no history of substance use. Our third patient was a 50-year-old male from China with a reactive HCV antibody but undetectable HCV RNA, no co-infection with HIV, no history of substance use. Our fourth patient was a 53-year-old male from China with a history of prior cocaine use. The labs showed the patient had previously cleared HCV and was HIV negative. And then the fifth patient in the RNA negative confirmed was a 53-year-old Hispanic female. The country of origin was unknown, but there was no co-infection with Hep C or HIV and no history of substance use. And then we had 2 antibody positives, but with an RNA unknown. So the first patient here was a non-Hispanic Black male, age 68. This patient had a past medical history of HPV and IV drug use and had been on HPV treatment, but had discontinued and had not been tested for HDV RNA. And then the second patient here was an 83-year-old female patient from China, who they were not able to obtain RNA for this patient, and she was lost to follow-up. So this takeaways slide is very broad because I'm really hoping that as we move through the next presentation and then start to stack up some Q&A and discussion points, we can dive into some of these more specifically. But I think some of the takeaways for us were that the guidelines are confusing and differ in their approach, which we knew going into this, but it made it challenging throughout the pilot as well. We also found that, of course, routine Hep B screening is paramount to successful Hep D screening, and that provider awareness of the Hep B screening guidelines really varies, and that seemed to be a big challenge for some of the sites. Um, Also, the lab costs and the processes, the challenges of these really varied across sites. I think I alluded to that a little bit, showing the different ways that samples were collected, the different labs that we're working with. Um, but I think just kind of having 8 different sites all trying to implement this and all going through similar but different experiences was helpful and enlightening. Um, so one of the biggest problems that I already flagged was this low rate of Hep D testing among our Hep B surface antigen positive patients. Again, it was only a 58% completion rate. Um, Sites reported that there was often confusion around which tests to use. For those of us who work in EMRs, a lot of times you might, type in a search and a million things come up and people don't always know, especially if it's not a test that's in their wheelhouse or that they're using regularly, they may not know which test to order. And then sample availability was also challenging, and we can talk a little bit more about that in the discussion time. But I think, again, because of the different lab processes that we had, sometimes by the time you ordered add-on testing for someone, that sample may have been discarded, or you may not have a sample. You need to bring someone back in to get the sample to do the RNA testing, and that is challenging. So there were a lot of these different challenges, which again, I'm happy to talk more. I think the biggest takeaway that we tried to hammer home was recommending a double reflex so that your Hep B surface antigen positive um, reflexes to the Hep D antibody test. And then if that's positive, that reflexes to the Hep D RNA. Um, and that I think is where we would love to see things go, but I I wouldn't say it's clear that they will. So I'm going to stop there. I think, again, there's lots more to talk about in the discussion, but hopefully I've given some food for thought. And I can turn it over. My info will be shared, I'm sure, but just want to also call out our medical director, Dr. Nancy Glick, who I work closely with on all of these projects. So I'm going to stop my share and I will turn it over. Thank you.
Great. Thanks, Bijou. That was a really great overview. So I think we're going to go, that was like kind of the macro level of the whole project and all the different sites. And it was actually really great, I thought, to be part of almost like a collaborative we had going on, being able to compare processes and learn from each other. And, if one place could do something, we would bring it back to our team and say, hey, let's see if we can try that. So I think that's very useful when you're actually trying to start something new. So I found that very productive. And then writing the paper was helpful too, just to, kind of analyze all of our information and compare. So, all right. So I'm going to focus on what we did here at Cooperman-Barnabas Medical Center. And you heard a little bit about our program and our hospital setting. And so I'll go into, some of these processes and what we found with our pilot screening. So we had, just so you know, this kind of this is embedded inside our larger screening program, the focus program that we have, which we launched in 2018. And originally it was just at Cooperman, which is kind of the flagship hospital of our RWJ Barnabas Health System, which includes 12 hospitals. And it's just kind of been growing even as this program was happening. And one of our bigger transitions that happened is we went from Cerner as an EMR to Epic. So that even, I think this happened with some of the other hospitals too. This happened during the pilot. We kind of had to transition and reprogram everything, which was a little tricky too. I'm sure it's very familiar to a lot of people. So overall, for all of our programs, we've screened over 277,000 patients. And at our hospital, which is CBMC, we have been doing Hep B, Hep C. We have an at-risk screening program from HIV, and then we did this pilot for Delta. We've added on 2 other hospitals. Okay, so first off, we started on the ED, and then we branched to the inpatient and cancer center within Cooperman. And then the Epic transformation helped because we were able to then more easily branch onto other sites because everybody had the same EMR. So we launched Hep B and Hep C at Somerset, which is a community hospital, and the Rahway, which is a hospital further south, and we do Hep B and Hep C at those. So on the right, it has our algorithm and how it's expanded. I'm not going to go into all of this, but you can see that the Delta, is it in here actually? It was one of our last things that we added on. So this is looking at the kind of countries that people are from. So one of our screening criteria for hepatitis B at the beginning was really just identifying people from certain countries. So looking at the endemic countries. So at registration, people were asked about what country they were born in. And so this is very helpful for us to understand our community, because if you only look at race, you don't have any idea where people are actually from or where they were born. So this was very illuminating in terms of our community efforts too, kind of understanding who we're serving. So these are our top countries, and you can see Haiti is the top country outside of the US that we did a lot of hepatitis B screening in. But we also have Jamaica, Ecuador, Guyana. And then in terms of like countries that might be more heavily burdened with Delta, you've got Brazil, Nigeria. And then when I go into this bar graph, this is like a larger spread of all of our countries. This actually, I think, this maybe, I don't know, may have my top, beyond just the top, I had just top 15 here, but there's more here. So you can see quite a diversity, some African countries too that are also known to be higher Delta. And I think we have quite a number of Asian countries like China, India, Pakistan, and the Philippines. So just to show you that New Jersey is quite a very international area. And what we found is that our percentage rates of Hep B were close to 1%. And the number of people we ended up finding with B were equivalent to the number of people that we found with C, which I think was a little bit of a surprise because I think more people are aware of the hepatitis C screening guidelines than hepatitis B. I think a lot of people realize, those of us in the Hep B world realize that there's a lot more awareness about C often than there is about B. All right, so how did we automate this? And I think so much of what came out of doing this project is like just how important processes are, and like knowing the limitations and kind of trying to think through, figure out, problem solve on how you implement something like this. So I think with basically, as Bijou mentioned, there's Hep C and reflex testing, which is helpful, like that people are aware of that kind of reflex test. Our hospital we had already helped implement the Hep C antibody with reflex to RNA. So our lab was very familiar with that and when they worked with us. And so what we did with Delta is something similar, where we said anybody who is surface antigen positive, we wanted them to basically hold the specimen. This is why your buy-in with the lab is really important, because basically every positive hepatitis B surface antigen test they had to hold, and then test it for Delta. And I know of some hospital labs that don't do any reflex testing, so that already is a win. So with the Delta antibody test, then we try to, I don't have that in here, but the RNA test is done afterwards. And we were not able to do the double reflex like some of the hospitals were that Bijou mentioned. But in terms of what happened with us in our EMR, we stopped Cerner basically stopped in October 23. We switched to Epic. And at that time, obviously, with all the priorities, there was so much other stuff happening that the Delta project, we weren't able to reprogram it, but we were focusing on reprogramming our other screening programs, the B and the C. And so we actually transitioned to not doing Delta at all in the hospital, but then we started doing more of it in our clinic. So that was a good experience too, for those of us in a clinic setting, to have to be reminded, it's obviously not a care gap, at this point, it's not at that level. Otherwise you do have care gaps in the EMR, but we ended up doing some manual reviews. So our staff actually would chart review, and then if they saw a patient with Hep B that didn't have Delta, they would send a note to the doctor to say, hey, you're seeing this patient tomorrow, can you add on a Delta test? So, I think that's, a little bit more manual, but it's still something in order to increase testing. So back last year, we were able to start programming the Delta again in Epic, now that things have kind of settled down. And so we basically tried to do the same thing that we had in Cerner in terms of all new surface antigen positive tests got reflexed to Delta antibody. So you can see we switched labs too. So we are now LabCorp, but originally started off on Quest. So this is a little dense, but basically this is, I've covered some of this already in terms of the algorithm. This is just talking about how important it was to like work really closely with our IT analysts for the Epic programming side, but also really closely with our lab leadership, because this all had to be coordinated. So I think any of you who have done any kind of, change work inside your hospital understand like it comes down to like, submitting a request to do this within your computer system. And then you end up in a queue, right? They have all these other requests coming from all these other different departments. So you just wait in line and wait until it's your turn. And then they let you know when they're working on it, and there's a little back and forth, and there's a chance to actually test whether it works. And usually there's a little bit of QA in terms of making sure it works, right? Because sometimes there's little glitches you don't anticipate. And so that all takes time. And then once all that is ready in terms of your algorithm, then when we talk about launch on the third bullet point, our hospital notified, they basically send a memo to the entire system. They have to let everybody know that we're doing this surface antigen to Delta reflex. And we also had to get it approved by the medical affairs team, like the clinical, all these things have to kind of be approved on administrative level. So initially when we launch, you kind of have to make sure it works. So our staff were doing chart reviews to make sure that the Delta was getting ordered on the back end. And initially there was a lot of manual checking to make sure that the antibody was working, and that if there was a positive test, we would actually get it. So initially what we found that the navigators were not getting the positive alerts, and the results from Quest, because their sendouts don't always interface inside your computer system. So we had to have that fixed so that it would interface and they would actually get the alerts. And then at the beginning, every time it didn't reflex, and Bijou mentioned, it was only 50% of all the surface antigens that got reflex. And, they're just like issues sometimes, like not enough sample, you can't kind of control that, but we wanted to make sure that it wasn't a system-based glitch. So, and then June 2024, when we went transferred to Epic, we did try to go to the double reflex, right, the gold standard, but we couldn't because the tests get done in different locations. So the antibody is done in one area, RNA goes somewhere else. So that second lab where the specimen goes for the antibody, they're not necessarily going to be able to send to that second, the third lab, I guess. So, it comes down to that. If you have both, you have the one site that can do antibody and RNA, then possibly, it can be done, or if it's done in-house, right? But that was our barrier. Let's see. So yeah. Yeah, they had to do with like which test, which lab we were using. Because I think it was Quest for the antibody, but then not Quest for the second one. So yeah, and then we had to kind of like weigh out, whether this was worth it, because the number was so small, to like create a whole system, from lab to lab transfer. All right, so these are our results. Of the 88 positive surface antigen patients we had during the pilot, we were able to test 77, so it was a little bit, more than the 50%. Of the 77 tested, we had 3 Delta antibody positive, so it's a 3.9% rate. Only one of those where we were actually able to get the RNA back, and that RNA test was negative. And Bijou, I think, reported on that patient. So these bar graphs are just basically month by month what our numbers looked at. The top bar is all the hepatitis B testing that was done. So this is all the screenings that were done. And then the number of positive surface antigen tests are in the blue. And then the green is like the number of patients who were able to successfully get that Delta antibody test. And then the light green down here where you see 111 are 3 patients, or the patients who were antibody positive. So it's just showing you the time frame. And then this is kind of looking at us when we moved to Epic. So the top part is when we were in Cerner, and then basically what we've done since we started Epic. So we have not had a positive Delta since we moved to Epic for the screening last year. All right. Let's see. Okay, I think this is basically the same thing. Spread out. Okay, so these are the 3 antibody positives that we had. The first one is the one that Bijou talked about, which was the one that we were able to get the RNA back. And the reason we were able to get the RNA back on her is because she was a renal transplant patient. So she was in the hospital for a really long time. So when we got the Delta antibody test back, she was still in the hospital. And so the navigator was able to right away send a message in Epic to the nephrologist and say, hey, do you mind adding a Delta test? And of course, they never ordered this test. So we had to walk them through like, oh, this is the test. This is the test code. So they basically just followed our instructions. She was negative. She actually sees a hepatologist too. So we just informed the hepatologist of her result, that she was antibody positive, but RNA negative. So she could keep an eye on her because there's some studies that show like people who are truly Delta positive potentially can have RNAs that are sometimes undetectable, sometimes detectable. And so there's some studies saying that repeat testing can help. And sometimes you do pick up people who are actually positive. So the last 2 patients, we were not able to get them back. So one of them was a woman who was from China, Mandarin speaking. She had come in for a fall. We had to use language line with the navigators, my navigators don't speak Chinese. And her phone number wasn't in service. She was completely lost to follow up. What we have is you can put a message into Epic Chart saying that it's called a return to ED alert. So if the patient comes back, there'll be a notice that says, please reach out to our navigators. That way we can try to get a specimen then. And then the third patient was actually a US born man who had a history of chronic Hep B. He came in for shortness of breath. He was actually seen he was hospitalized. He was admitted into the hospital, and he was seen by an ID doctor. And they said that they were aware. And then we just weren't able to get the result once they went. We don't know if it's unclear if he went back to that practice. So the ID doctor, I think, was managing his Hep B anyway. And I think from the notes that we saw, it looked like that the provider was aware. But we ourselves were not able to get the Delta test. So basically, in summary, we're able to successfully implement this automated testing. Took a lot of work in terms of just collaborating, but once we did it, it was much easier to do it the second time around with Epic. And so I do think this is doable, and it's obviously easier to get that reflex when the patients are still in house, or if you can get the double reflex. So challenges, the turnaround time for the Delta test was long. It was about a week, I think. And so by that time, a lot of patients were already gone. And it needed an additional order, right? So it wasn't even it required a doctor ordering it. So we were lucky with a kidney transplant patient. The nephrologist didn't mind being the one putting in the order. But that was something our navigator had to do. And then, yeah, so it's hard to get people back for a test too once they've left. And then part of it was like the hospital isn't really set up for people to come in from the outpatient setting to come back in to go to the hospital to get tested. So a lot of it would have been like, oh, if you're going to your primary care doctor or your infectious disease doctor, they're the ones that are going to have to test. And they're not necessarily always motivated to just go somewhere to get one test, especially if they feel fine. So these were some of the issues that we had, and this would be great for us to talk about too, especially if there are any other physicians or providers or systems that have tried to do something similar. So I will close there and hand it back to you, Beatrice.
Great, thank you so much. This is a really fascinating study, and I think so important, to just get a better understanding of hepatitis delta overall. So we again encourage any audience members who have questions to please just make use of the Q&A box, but I can get us started as I have quite a few. Let's see, I was wondering, it seemed that some sites were able to have double reflex testing more or less enabled. And I was just wondering what the difference was between those sites that allowed them to have that, if any, if I understood correctly.
Well, I think maybe you're referring to the slide with like the circles and squares,
Yeah.
right? Yeah, I think what I want to clarify there is we were really careful to use this language of manual reflex testing because and it was a nuance that I didn't fully appreciate until actually the lab lead at Norton, one of our pilot sites, really called this out to me because I think that when we think about Hep C reflex testing, I'm assuming a lot of people are in a space where you're familiar with Hep C reflex testing, and it all sort of like marches forward without really anybody having to really do a lot or think a lot about it. And that was not the case with the manual reflex testing. So even though some sites could take the same sample through the testing cascade, that did not mean that everything was being done automatically in the sense we would use with like Hep C reflex testing. It was a very manual process. Someone still had to keep track, or I think Sue alluded to this and maybe can speak a bit more of it, but like where the lab has to actually like hold these samples aside and then place an additional order for them. I remember when the lab lead at Norton was explaining this to me, and I was trying to wrap my head around it. I created this like Quiznos sub analogy where like you put the Quiznos sub in and like it toasts and it comes out the other side and like the sub is there. Like that's kind of like how Hep C testing works. Like you put it in the machine and it comes out the other side. But this manual reflex testing requires a lot more touch points by either lab personnel or programmatic personnel or both. And so it's much less seamless than what we tend to think of when we talk about reflex testing. I don't know, Sue, if you wanted to add anything to that.
Yeah, no, I remember that now. What we call reflex is different at different places. So that what she's talking about is like some places didn't necessarily have like the lab reflex, but they still called it reflex, based on their protocol. But there are places that have, and it's going to be less now because of FDA rules have changed, but in-house, I think Mount Sinai, New York City, don't quote me, but I believe they had in-house Delta testing. So it made it easier for them to do. And I don't remember if they had RNA too, but they definitely, I think, had Delta antibody testing. And so they even had a ambulatory like care gap for Delta. And I mean, just from what I remember talking to Tatiana Kushner when she was there, like they had a really good reflex program. So sorry, I realized I didn't finish my last slide because it didn't move to it. And so I had like some takeaway points. And one of the things I think is an asset is when you have navigators who kind of like, or people who work with like the patient on multiple things, because obviously a lot of it is having to like call a patient in. So if there's, if you're already working with a patient because they're your patient for something else, adding the Delta is easier than, a standalone program. And then, I'd love to talk about at some point, I think we have to answer other questions like what some of the takeaways moving on from this would be, because this is kind of a pilot, not all the programs continued it, and whether people think in the end, and Bijou, I don't know if you've had conversations with other hospitals, like whether they would continue with this like automated screening or whether maybe they would do more targeted screening. That's kind of what we were thinking. Maybe you might want to do targeted screening just so you have, more of a chance of finding somebody. But anyway, Beatrice, I'll go back. You have another question?
Yeah, I'll follow up on that in a second, but we do have a question in the chat. If there were any insurance aspects that had to be navigated or taken into consideration with the EHR auto reflex testing.
So we did have to, like, as part of the whole proposal for this, talk about the cost, and the Delta antibody test is actually not that expensive. So that was not it was not an issue, and it is because it is a clinical recommendation. It's not like we were doing, and it's not like we're doing a clinical trial, trying out some intervention that wouldn't otherwise be indicated. But so it ended up not being an issue. And, as you can see, the numbers in terms of people who actually needed RNA are very little. So the burden on the system is really not a lot.
Yeah, I
Did you
think
that came up with the other places too?
I don't know so much about the insurance discussion at other sites. It was surprisingly not something that we talked a lot about, and we had a lot of meetings across the collaborative. Um,
Yeah, I know when I've ordered it in the office, it's like not one of the tests that gets rejected. Like, I want to
Yeah.
say it was like less than $20 or something. It's something, you know, it's actually cheaper than like a Hep B DNA test or a Hep C RNA test for sure. Like the RNA is more expensive, but the Delta antibody itself is inexpensive.
Yeah, we were able to obtain some support for our lab costs. And I did have discussions with the lab director about the RNA, because if you'll remember when I was with the squares, I was saying we would take the Hep B surface antigen positive and we would do both the antibody and the RNA test on that same sample. So we were
Mhm.
testing RNA on patients that we didn't even know if they were antibody positive.
Oh, wow. Yeah.
And my lab director was like not really crazy about it, but for the pilot, I was like, listen, if we don't do this, I mean, I think Sue, you had a point in one of your slides, like bringing people back in for the collection for the RNA test is very challenging. It's a tough population, and I think I was reading your point on your slide, like by the time we reach out to people to be like, ew, there might be something going on, we need you to come back, like whatever brought them into the hospital, like they've moved on, they've checked out.
Yeah.
We're calling and saying you might have something. Like they're just like not a real urgency, I think. And so bringing people back to get that collection, we don't have good data on like how well sites did that because we didn't have that many antibody positives. But my guess is that if we had had a ton of antibody positives and it was reliant on bringing people back in to collect another sample for RNA, we would have had yet another huge drop off in completion of those tests. And to Sue's point, like doing that without a navigator, I think would be just about impossible. The
Well,
only chance you
yeah.
have to get those people to come back in for that follow-ups collection would be that you have a patient navigator that's just like they are just dedicated to that task.
They are dedicated, that's for sure. Yeah. So yeah, I've got my two navigators are on the call. So a lot of kudos to them with like repeat phone calls, being persistent but polite, texting, whatever method works for patients, they're amazing at.
Yeah.
Yeah, absolutely. It's so important for closing the loop for sure. One thing I think, Bijou, you had mentioned was that guidelines and kind of lack of clarity around them contributed to the difficulty of testing. I was wondering if you could just expand on that a little more, and how changes in that area might help to increase testing more broadly.
I think Sue is much more well positioned to speak to that. The only thing I will say is like because the guidelines are so clear, it's hard to approach your system leadership and say we should be doing X or we should be doing Y, because it's like, I mean, I guess if you find the thing that supports what you want to do and then hope that they don't find the thing that doesn't support what you're asking for, then like maybe you win that battle. But yeah, I mean, I think Sue, you should take this one, really.
So say it again, it was a question about recommendations or?
Yeah, and
Yeah.
how in their present form they make it harder.
And there's just like the conflicting guidelines from different groups.
Yeah. I think, the average person is not going to be drilling down to the double ASLD, 90 page guidelines or whatever. And I think, there are guidelines out there that say, that we should be screening more, right? We're missing a lot of people. And so, yeah, that didn't come up like you're saying. I think we were able to make the case, and I think you can often go look at the liver cancer as an approach, right? Like that you want to be able to find people early on who are at risk of liver cancer. And our liver cancer rates that we had looked at show that we were finding people too late stages. So we have a very high percentage of people showing up with liver cancer already in stage 4. And so we often use that as the impetus and the data kind of showing why we need to do more of the screening and more early detection. So yeah, and then as you can see, like the numbers are small, like we're only doing, less than 10 a month. So it's really not a huge burden on the system to do it. So I think that was helpful. And then you know, I think calling it a pilot is helpful too, because it's like, okay, let's just see how it works, right? If it's a disaster, it takes up too much resources, you don't have to do it, but you don't know until you actually conduct the pilot. So I think that helps to kind of, you know, ease a system into something new like this.
Yeah, absolutely. And then you had mentioned potentially doing targeted testing as something that might come out from this, given the low kind of low prevalence that was found. Could you just say more about what you mean by that and how that might be a more helpful approach, possibly?
Sorry, Beatrice, I just saw that I'm answering Carla's question on the Q&A. So tell me
Oh,
again
cool.
what your question was.
Oh, sorry. Just about targeted testing and how kind of what that
Oh,
might look
yeah.
like.
I think so. We were brainstorming this, like saying, you know, if we don't have funding moving forward for this, you know, what would we do? Would we continue to do this? And I think we had said, you know what, we might actually, because I'm not sure that the investment, you know, necessarily reaped a lot of like return. And so we are saying maybe certain high risk populations, like people from certain countries, or if they're, you know, IV drug use, or if there's, you know, certain ways where we can target kind of our risk patients who are, you do find are having like more fibrosis or potentially cirrhosis. You want to make sure all those patients get screened. So we hadn't decided, but I think that was kind of like next step in terms of, you know, what makes sense. Or I've heard this discussed, you know, maybe it's not the first test you need to do when somebody is just finding out they have Hep B, like maybe you're getting them into care. Maybe the ambulatory setting is a good place. Like maybe it's something that's in the list of other tests that a Hep B patient needs, right? Like they need a Hep C test, HIV, other things you're screening. Maybe it ends up in some sort of prompt there so that you can do it in this way where you know they're following up, right? They're my patient. They come regularly, you know, I'm not going to lose them. I'm not going to fret over losing these people, right? Because that's the thing. If you're going to do a test in the hospital and you need another follow-up test, you know, it feels irresponsible to test, but then if you can't get them back in, you have this like hanging over you, right? This person's incompletely screened. So that might be a more realistic thing. And, you know, of course we'd have to get IT to make some of those changes in our ambulatory setting, but I bet some of the FQHCs do a good job. Like I'm thinking about NEMS because they have this amazing Epic module for hepatitis B with a lot of like care gaps and like care sets for hepatitis B. Like that, it might be a really good model to look at.
Yeah, absolutely. They do definitely a good job with that.
I also
And
think
then,
when thinking about doing anything targeted, like the quality of data that we collect on certain things like risk factors, or like, I mean, the amazing slide that Sue shared with the breakdown of country of origin, like I just think the quality of data that we have available in the EMR is not always great. So trying to think about like working with what you have can feel fairly limiting sometimes if you're not in a setting where you're getting really good quality data on those things from your EMR.
Yeah, it takes a lot of work to get good reports. That's for sure. I mean, I think with Epic, we're surprised at how difficult it seems sometimes to get basic reports. So you are often limited by what, you know, what data you can get back.
yeah, absolutely. Do you think that so I know, you know, without having an approved treatment in the US, at least, that can, or even outside of Europe for hepatitis delta, that can influence, you know, willingness to test for hepatitis delta in general. Do you have any thoughts on whether that might change going forward? I know that's kind of outside this pilot program, but if that would, I don't know, move the needle at all on more widespread testing.
Yeah, I think as things change and we have like curative treatments, and even, I mean, something that came up during our during this pilot was like FDA approval of tests, right? Bijou, remember, like that was a big point of discussion. Like none of these tests are currently like FDA approved.
Yeah.
So you can have a homegrown lab and you just don't know the sensitivity, the specificity, right? Like there's variability, which is, you know, a little concerning. And so I think I remember as a collaborator, we were also often having these discussions, and like we would hear every once in a while, oh, there's supposed to be an FDA approved test coming soon. I think it's supposed to be soon still. So I think that would help also, right? If there's more standardized, high quality tests that are out there.
Yeah, I think we called that out in the paper, and I remember when we talked about it, it was
Yeah.
also soon at that time too, and it's
Yeah.
it's kind of like,
A year
what?
later now.
Yeah.
Yeah.
Definitely. I think having a point of care test also for hepatitis B be approved can also go a long way as well, especially, in terms of loss to follow-up, et cetera.
For sure. Yeah, just going back to the test, Carla Coffin had just asked if I knew which test we used. And I know we asked before and I can't remember now because we also moved from Quest to LabCorp. So I just asked my navigator to see if she could track down which test we use, but we'll let you know.
Yeah, and I'm not sure for our site at Sinai. I was more just like, can we make this happen? I asked fewer questions about the logistics of what was going on behind the curtain. Can we do
Yeah,
the testing? Are we doing the testing? Great.
yeah.
Yeah.
Yeah, so I think some of the tests in like some of the hospitals that were doing this in-house were able to develop, like their labs were able to develop an in-house test, and you can do your own validation and stuff. But I think FDA is not allowing that. So I think a lot of tests, I mean, hospitals will have to use outside labs.
Yeah, and I think it's such a good point that you mentioned about because I know we were in this boat, and I think some of the others were in the pilot were in the same boat where when you think about this like ideal scenario of a double reflex, like all of your hopes and dreams are crushed when you realize that like one thing gets done at this lab, another thing gets done at this lab, like that that real like smooth pathway becomes pretty bumpy pretty quickly. And no one's gonna like change all the processes that are going on at your hospital just so that you can get, this double reflex path laid out.
Right.
So it's really challenging.
Just a few patients.
Yeah.
And like the specimen, one of the things is specimen is only good for like a week. So, by the time you get the antibody test back, it's like the specimen's no good for the RNA. So that's why your lab, basically just did them all, right?
Yeah.
That increased your chance of being able to get the RNA test.
Yeah.
Uh, and
Yeah.
Carla just mentioned that she's heard about a new point of care for Delta, which would be amazing. Yeah.
Yeah. That would be absolutely.
Carla, is that Delta antibody, I'm assuming? And then you'd have to do the molecular test for the RNA. Yeah. So, but at least that patient would know they were positive, and they're much more likely, or on the spot, you could do the blood draw for the RNA, right? So it would help. Yeah, she said antibody. Okay.
Wonderful.
Well, some
Well,
exciting things on the horizon then, it sounds like.
Yeah.
yeah. I hadn't heard about the point of care for Delta, so that's amazing, if that were to come to pass. So, well, thank you so much again for your work and for joining us today. This has been a great discussion, and I think really captures the huge myriad of challenges that come with hepatitis Delta testing, and what there is to solve in the future. So, and I think Rav has said that there are amazing new developments as well in the chat. So. So thank you so much again. I think we are just about at the top of the hour. So we will go ahead and close out, but just wanted to say thank you very much again to Dr. Wang and Bijou for joining us today. And thank you for all of our audience members for participating. We hope that you found this to be informative and valuable to your life and work, and can apply some of this moving forward. Again, the recording for the webinar, as well as the slides and contact info for the speakers, will be shared out following the conclusion of the webinar. We also encourage you to complete the evaluation form when the webinar concludes, and to sign up for some of our hepatitis Delta newsletters that we have for both providers and those living with and affected by hepatitis Delta, to be added to our mailing list. And that way you can receive regular updates about things like drug development, clinical trials, research, news, and events like this one. So I will add the links to sign up for each of those in the chat. And they will also be shared following the conclusion of the webinar as well. So thank you so much again. Please also feel free to reach out and get in touch with us if you have any additional questions, and to check out our program as well. And if you have any additional questions for follow-up. So thank you very much again. Thank you to our speakers, and I hope everyone has a wonderful afternoon.
Thank you.
Thank you.
Bye.
Take care. Bye.